transcranial magnetic stimulation and alcohol addiction. So this is my overview. I will start with an overview about all the neuromodulation techniques that exist and their application in addiction. Then I will talk about the effects of high-frequency repetitive transcranial magnetic stimulation and alcohol addiction. And I will end by discussing the effects of an accelerated TMS protocol in alcohol-addicted patients regarding relapse. So there are different neuromodulation techniques. There are invasive techniques and non-invasive techniques. The non-invasive techniques are transcranial direct current stimulation, or TDCS, and transcranial magnetic stimulation. And then you have invasive techniques, which are deep brain stimulation, vagal nerve stimulation, and electroconvulsive therapy. Transcranial direct current stimulation is a neuromodulation technique where two electrodes are placed on the head. Most often it's the dorsolateral prefrontal cortex, or the DLPFC, in alcohol addiction. So you have a positive anode and a cathode, and the direction of flow is between the anode towards the cathode. The region under the cathode is inhibited, and the region under the anode is activated. During the stimulation, patients remain conscious. So the first research that was published was in 2008. Fragny evaluated one stimulation session in smokers, and he found that whether you stimulated left anodal, right cathodal, or right anodal, left cathodal, there was a positive effect on craving. So craving decreased in smokers. Then later there was a study performed by Boggio, where 27 smokers were stimulated in 5 consecutive days. They received 1 session each day, and they found a decrease of craving over time. Then there was also a study done in alcohol addicted patients, and here also there was a decrease in craving for both active stimulation sessions. Then there was a last study in cannabis patients, where also there was a decrease in craving. So TDCS can decrease craving in addicted patients. Then you have deep brain stimulation. Here 2 electrodes are implanted inside the head. This technique was especially used in Parkinson's disease. And regarding addiction, you have 2 sorts of treatment applications. You have DBS, where it's applied in patients with an anxiety disorder, and they found an effect on a comorbid substance dependence. Or you have DBS, which is used for a primary substance dependence disorder. So for the first case, there are only case reports that have been published. Those were cases where DBS was applied in obsessive compulsive disorder, and they found that patients smoked less or drank less alcohol, or completely stopped. And then for the other, there are 2 studies, one performed by Kuhn and the other by Voges. And here you found that DBS could reduce alcohol consumption, or could make them completely abstinent over a follow-up of some months to some years. And also this was the same case for heroin-dependent patients. The stimulation place in humans is always the nucleus accumbens, but in animal research also other stimulation sites have been evaluated, such as the insula medial forebrain bundle, subthalamic nucleus, lateral habenula, and all had positive effect on the addiction. Then you have vagal nerve stimulation, which is an electrical stimulation of the afferent of the nervus vagus, and it's often used in depression. Here in addiction, there are no human case studies. There's a study done in animals where heroin-dependent rats were stimulated, and they found that there was a decrease of heroin reinstatement after heroin priming and also after the exposure to heroin cues. Then the last stimulation technique is electroconvulsive therapy, which is probably well known because it's extensively used in depressive disorder. Regarding substance dependence, the results are very outdated. There was a study in 1966 that evaluated ECT in 6 dependent patients. Most of them were morphine dependent, and there was a positive effect. But then nothing was published, and that was probably because ECT became unpopular. And when the EPA published guidelines for ECT, addiction was not in them. And probably that's the reason why there are no longer studies evaluating ECT in addiction. Then to come to high-frequency repetitive transcranial magnetic stimulation. This is in fact an electrical stimulation which uses an alternating current inside the coil, this coil, which is placed against the patient's head. During the stimulation, the patient remains conscious, and the alternating current makes that there's a magnetic field which is the strongest in the middle of the coil. You can administer it as a single pulse, and it's called single pulse TMS, or you can deliver multiple pulses, and that's repetitive TMS. Then you can distinguish between low frequency and high frequency stimulation. Low frequency is when you administer pulses at the rate of 1 Hertz or less, and high frequency stimulation is more than 1 Hertz. Most often it's 10 Hertz or 20 Hertz that is used. In addiction research, it's most often the dorsolateral prefrontal cortex that is stimulated. And the magnetic field that is developed enters about 2 centimeters in the brain. So it fades out quickly. What we did before is we evaluated one such a session, which takes about 10 minutes. And we evaluated the effect in detoxified, hospitalized, alcohol-dependent patients in a randomized placebo-controlled crossover design. We evaluated the effect on craving and on cognition, more in particular response inhibition and attentional control. These two, craving and cognitive problems, are very important in alcohol addiction because they lead to relapse. So we wanted to see what the effect was of one session. We used a go-no-go task, so patients were put before a computer and they saw a cross or a plus. When they saw a cross, they had to push a button as quick as possible, which was a go condition. And then when they saw the plus, they were asked to not respond to the stimulus. The no-go condition is a measure of response inhibition, so impulsivity, and the go condition is a measure of attentional control. It says something about their concentration. We also administered the obsessive-compulsive drinking scale to see how RTMS influenced their craving. So we included 50 patients. There were some dropouts, and there were 29 patients left. They were randomized to either an active group or a placebo group. 1 week later, they received the other stimulation, and just before and just after, they performed the go-no-go task and the obsessive-compulsive drinking scale. The obsessive-compulsive drinking scale was followed for 3 days after stimulation. And what we found was that we could not find an effect on craving until 3 days after the stimulation. We could also not find an effect on response inhibition, but that was probably because our go-no-go task was much too easy for the patients, and the patients already made not much mistakes before the stimulation, so it was a bit difficult to enhance their cognition. But what we did find, and this is important, is that after one session there was an increase in attentional control, so patients could concentrate better on the task during the stimulation. Attentional control is assessed as the reaction times to the go stimuli became much more stable after one such session. So patients become less distractible. Then there were other researchers that evaluated multiple high-frequency RTMS sessions. The most extensive research lately was done by Mishra in 2015. They included 20 detoxified alcohol-dependent patients, and half of them were administered 10 daily left DLPFC sessions. So in 10 days they received 10 sessions, 1 session per day, and the other group received them at their right dorsolateral prefrontal cortex. After stimulation, both groups decreased in alcohol craving, and there was no difference in anti-craving efficacy between both groups. Another group in 2011 evaluated The left DLPFC stimulation also 10 sessions in alcohol-dependent women, but they could not find a reduction in craving in this group. And then Mishra also performed a study before in 2010, which was a placebo-controlled session, and they found that active stimulation could in fact also decrease craving when it was administered at the right DLPFC. Here also relapse was followed, and they found that after the active stimulation, 14% relapsed, and in the placebo stimulation, 33%. This difference was not significant, but these numbers are important because I will come back to them later. So relapse, it occurs very often in alcohol-dependent patients, about 80 to 92% relapses within the year after they were treated. Before there was the definition as relapse as binary, or patients had a drink or they did not have a drink, but then later on the definition evolved, and it was better to speak of different outcomes, such as when was their first drink, when was their first heavy drinking day, such as a heavy drinking day is the consumption of 5 units or more per day by a man, and for a woman it's 4 drinks per day. How many abstinent days are there in the week, and so on. So as this morning was also discussed, pharmacological and psychotherapeutic options are not always beneficial. And a minority is an actual treatment. And the reasons for this treatment gap are that the problem is often not acknowledged. There's a desire to not involve outside help, financial problems, stigma, the belief that it will pass by itself, and so on. The predictors of relapse are craving, stress, severity of alcohol dependence, cognitive dysfunction, and especially impaired response inhibition, and then changes or adaptations at the neurobiological level. Regarding these neurobiological changes, there was an important study performed by SEO in 2013 who found that the best predictor for relapse are the nucleus accumbens, the anterior cingulate cortex, the ventromedial prefrontal cortex, and the precuneus, and especially the ACC and VMPFC are important to distinguish future relapsers from abstainers. And from other research, we know that rTMS is especially able to influence the anterior cingulate cortex and ventromedial prefrontal cortex. So to come to our major point of the presentation, what we wanted to know is that whether baseline brain activation during an alcoholic cue exposure could predict alcohol relapse after accelerated high-frequency rTMS. What accelerated high-frequency rTMS, I'll explain in some minutes. And we hypothesized that especially there would be a hyperactivation of the ACC and ventromedial prefrontal cortex during the alcohol-related stimuli in the abstainers. Then our second goal was to evaluate how 15 accelerated sessions would influence this relapse neurocircuit in detoxified alcohol-dependent patients. Here we hypothesized that rTMS should only affect the relapse neurocircuit in abstaining patients. So what we did was that on Monday we started the protocol. Patients were confronted with an alcohol-related design. They saw alcoholic pictures and neutral pictures, and from neutral pictures we chose to present houses. And then during the 4 days that followed this cue exposure, they received multiple sessions per day, in total 15. On Monday they received 1 session, Tuesday 4, Wednesday 5, and Thursday 5 sessions. These sessions, that's what's called an accelerated protocol. In dependent patients, it was never been done before because it was not clear whether it was dangerous or not for the patients, because TMS can provoke an epileptic seizure. So when they received their sessions, after their sessions, they were again confronted with an alcohol-related cue exposure. And 4 weeks after this last cue exposure, they were found to see whether they had consumed an alcoholic beverage. So we included 29 recently detoxified alcohol-dependent patients who were hospitalized at the time. We lost 10 patients. We could not reach them. And the 19 remaining patients, we had 13 relapsers and 6 abstainers. So the relapsers, those were the patients who had consumed at least one alcoholic beverage in the 4 weeks of follow-up. Between the two groups, there were no differences at gender or age, the benzodiazepine-free days before stimulation, or the heavy drinking days during the last month before the stimulation, or the duration of the alcohol addiction in general. So for the relapse rate, we had a relapse rate of 68%, which was very high. Compared to the Mishra study, it was much higher. He had a relapse rate of 40% to 33%. It's difficult to say why that is. It's not easy to compare because they're two different protocols, but it could be that the accelerated protocol is less beneficial or less efficient. There was a difference between our patients and their patients. It was our patients had their alcohol addiction had a duration of 5 years longer. But the relapse rate was about the same as patients who were treated with naltrexone or acamprosate. Then when we look at the neurobiological level, we did a region of interest analysis, and we found that at the interaction level, there was a change in dorsal anterior cingulate cortex activation. So when we look at the post hoc test, we saw that in the abstainers had indeed an increased activation of the dorsal anterior cingulate, which could indicate they had an increased cognitive control. So this confirms our first hypothesis. And then when you look at the effect of TMS on both groups, then you saw that this DACC activation decreased in the abstainers, which is not a good thing because you would expect that DACC activation is high, so it would mean that they had increased cognitive control. And in the relapsers, there was an increase of this DACC activation. After the stimulation, there was no difference between the two groups. So this did not confirm our hypothesis, our second hypothesis. And what we did then, because of this differential effect of TMS on DACC activation, we plotted the baseline DACC activation versus the percentage change of this activation in this region after TMS. And what we saw here is that at those patients who were at baseline a higher DACC activation, the abstainers, had a larger decrease of this activation. And here at the other side, you have those with a very low baseline DACC activation, and they have a larger increase of their activation. So this is consistent with a rate-dependent effect. And a rate-dependent effect means that the effect of TMS is dependent on your baseline DACC activation. So how can we interpret this? We have to keep in mind that it is in detoxified hospitalized patients, and that it is during the exposure to alcohol-related stimuli. One could wonder whether this application is relevant in those patients with a baseline or a high DACC activation, which were the abstainers. And then in those patients with a low DACC activation, which were the relapsers, they have a larger proportional increase of DACC activation, but apparently they do not have a clinical effect because they relapse. So this could mean that there's a short duration of the treatment, or it could also mean that the dosage is not enough and that you have to stimulate more and more intensive. Of course, we have some limitations. We had no placebo stimulation. We had also no control group that received treatment as usual and that we phoned 4 weeks after their stimulation. How are you doing? Have you already consumed alcohol? We only have information about alcohol lapses, and lapses are not always a good predictor for a full-blown relapse. And then for future research, what would be very interesting is that in those patients with a low DACC activation, that you would evaluate a larger number of placebo-controlled high-frequency RTMS sessions to see how this affects their relapse. And of course, because high-frequency RTMS, there's there is much more to be evaluated, such as which side do you have to stimulate, left side, right side, do you have to stimulate at a high frequency, a low frequency, which frequency. Those are all things that still needs to be examined. So the takeaway message is that 15 accelerated high frequency RTMS session, we had a very high relapse rate. The abstaining patient had at baseline more cognitive control because their DSCC activation was higher. Accelerated TMS had a rate-dependent effect on DSCC activation, so the higher your DSCC activation at baseline, the larger your decrease, and the lower your DSCC activation at baseline, the higher your increase of activation after TMS. And there was a limited effect at the clinical level. So possibly the TMS effects could be short-lived. So thank you for your attention, and I also want to thank my collaborators in the university hospital.